Welcome to our case study on Sophia Lord. Our group members consist of Judy Liu, Andrew Napolitano, and Kim Truong. First, we'll be talking about Sophia Lord, then we'll go into her diagnoses, of which she has 3, and we'll finally end with the settings until her eventual discharge. So Sophia Lord is an 80-year-old female that recently had a total hip replacement. She was referred first to acute to have an evaluation and treat her total hip replacements and also educate her on her posterior lateral precautions. She has a previous medical history of osteoporosis and osteoarthritis in her hips. Before her retirement, she was a school teacher, so she was educated. She is a recent widow. Her spouse died 6 months ago, and she's the mother of 2 adult children and a grandparent to 3 children. Before her total hip replacement, she was independent with ADLs and ADLs with limited functional mobility due to the osteoarthritis in her hips. She is currently on oral pain medication for 1 month. Her physician allowed her to have full weight bearing, and she's financially secured due to retirement, and her daughter is there for social support. Let's talk about what brought her into the acute setting in the first place. Her first diagnoses, which is a hip fracture. Due to her osteoarthritis and osteoporosis of the hips, Sophia Lord makes a good candidate for a total hip replacement. She had her hip replacement done and must now follow posterior lateral precautions. These precautions include not crossing the legs at the knees or ankles. So when they're sleeping, you must use the pillow between the legs. Not bending your body or your torso past 90 degrees. So this means that she can't lean when she gets up, and she can't allow her knees to go higher than her hips. And when she goes to the bathroom, she must use a raised toilet seat. She also must keep her toes straight. So when she's sleeping, she must not allow them to rotate externally, and to also take small steps.
Sophia's second diagnosis, midshaft humeral fracture, has been treated with a non-operative conservative rehabilitation treatment, which includes a brace with a collar cuff. A collar cuff can be discharged from 4 to 6 weeks, and the brace can be discharged within 8 to 10 weeks. The precautions with the collar cuff or the humeral fracture precautions in general are no use of the affected extremity in ADLs, no lifting, pushing, pulling with the affected extremity, and no leaning or resting on affected extremity elbow. Basically, no weight bearing. The following is an outline of the conservative treatment protocol for a humeral fracture with a brace and collar and cuff. Day 3 through 7, the OT educates on precautions and one-handed ADL techniques. She shows PROM, Codman's pendulum exercises. For the patient will do 6 times a day, 5 minutes each time. Edema management and wrist and hand AROM, basically range of motion of the unaffected joints. Weeks 1 through 4, she continues to monitor brace fitting and hygiene, edema reduction, and perform PROM, Codman's pendulums. In weeks 4 through 6, upon collar cuff discharge, she can move on to pulley, active, assistive range of motion, shoulder flexion, and elbow range of motion. Then also light ADLs, feeding, and buttoning can begin with her affected arm. Weeks 6 through 8, light weight bearing, light functional activities, and more shoulder active assistive range of motion planes can occur with the pulley. Also gentle isotonic elbow exercises. Week 8 through 12, upon discharge of the brace, she can perform shoulder passive stretching, and strengthening exercises can begin, i.e. TheraBand, light lifting to full resistance. Finally, week 12, she should be discharged from humeral fracture rehabilitation.
Cognition. Sophia Lord has signs of early dementia, which affect her global mental function, and contributing to her occupational performance difficulty. Sophia is having difficulty learning and retaining hip precaution, performing her ADLs, even though her motor skills to perform these activities are intact. OT approaches to improve Sophia Lord cognition function. The executive function performance test will help to identify Mrs. Lord's problem area in her occupational performance. Plus, the dementia rating scale to assess changes in ADL, personality, interest, and drive. Reality orientation, clock in view, calendar in view, family picture in view, environmental consistency promoted, social participation promoted.
Let's talk about the acute setting in which we see Sophia Lord referred to first. So Sophia Lord is first introduced into an acute care facility 1 day post-surgery after her total hip replacement. She has full weight bearing with posterolateral hip precautions, which we touched upon earlier. These precautions are important because they interfere with her ability to do her occupations. For example, her ADLs, being able to bathe, being able to dress, being able to do personal hygiene. These interferences can cause her to have problems in her occupational performance, and thus we as or acute settings must be aware of these and educate the client on ways to adapt. There are hip kits that are available, and they can be used as adaptive tools to help the patient, such as Sophia Lord, do the activities that she wants to do. Acute settings in general are only very short in a time frame. For her long-term goal, which is only going to be about a week long, we would like Miss Lord to be able to independently practice ADLs while utilizing hip precautions by using the provided assistive tools as needed within 2 to 3 sessions. We also have 3 short-term goals included. The first is Miss Lord will recall and repeat all 3 posterolateral hip precautions without verbal cues within 1 session. The second is Miss Lord will demonstrate donning her shoes, socks, and pants with the use of adaptive tools 2 out of 2 times within 2 sessions. And the last short-term goal is Miss Lord will demonstrate safe tub, bed, and toilet transfers using assistive devices if needed within 2 sessions. In acute, we'll be using a biomechanical frame of reference, and we'll be using modifying and preventing approaches for our interventions. We'll be looking at her performance skills, her ability to process, and her ability to use her motor skills. For her performance patterns, we'll be looking into her routines and habits. And for her client factors, we'll be checking her strength, her range of motion, and her endurance and tolerance for the activities that she'll be doing. The activities and interventions that we'll be doing for Sophia Lord include performing her activities of daily living with the use of adaptive tools as needed. This includes the ability to dress and to safely transfer from one surface to another until competence is achieved. The reason for this is that we want to apply the safe techniques to her home environment. We want her to be able to safely transfer and safely dress herself without breaking her hip precautions and causing complications. In acute, we'll be working closely with the PT and also with the physician as needed. In Sophia Lord's case, we will not be required to work with speech-language pathologists, but we have been known to work with them in the acute setting. We are located in an acute care facility, and we'll be seeing Sophia Lord at least once a day. The frequency is 2 to 3 times a week for 45 minutes to 1 hour sessions before her discharge to the appropriate facility, in this case, subacute.
In the acute setting, the expected length of stay will be 2 to 3 weeks. The summary of the occupational therapy focus
For the rehab setting will be ADLs, self-care and functional mobility, IADLs, health management, home management, meal preparation, and safety maintenance, rest and sleep, sleep preparation and rest, leisure, leisure exploration and leisure participation, and social participation with peers.
So, now that we have discharged from the acute setting, she now enters the rehab setting, in which her occupational performance problem areas include ADLs, IADLs, rest and sleep, leisure, and social participation. Her ADLs are basically just a turnover from her acute setting. Her IDLs now are health management, maintenance, home management, meal preparation, safety and emergency maintenance. Her rest and sleep includes sleep preparation, understanding sleep routines, establishing healthy sleep pattern, and rest, establishing periods of rest during energy-taxing occupations. For leisure, includes exploration and participation, and social participation with peers. Now, going on to her goals, her long-term goal is that she will be confident in and modified independent and safe execution of ADLs, complete IADLs necessary for safe, independent living at home with minimal assistance, and maintain a healthy sleeping pattern by discharge. Her short-term goals include number one being able to execute an energy conservation rest breaks while performing any energy taxing activities such as bathing, functional mobility for long distances in her dwelling, and cleaning by day 2. Confidence in safe execution of all ADLs with supervision following HIT precautions by day 4. And she will perform health management, home maintenance, safety management, and financial management IADLs with 2 or fewer cues for each IADL by day 6. Cause of her problems include performance skills, in which are process skills, accommodation, organization, and inquisition, and motor pacing. Her performance patterns are routines, sleep pattern, habits, denial of problems when asked, and reluctant to perform activities without encouragement. Client factors include muscle endurance, global mental functions, temperament, energy, and drive, and sleep, and mental functions, all the higher level cognitive functions. Activity demands or space demands, space for safe functional ability, same as in ADLs. For sequence and timing, conducting financial management, IADLs, and meal prep. Objects used in their properties include adaptive tools for dressing and mobility, same as acute. And relevance are safety, independent living, skills, and increased energy, and required body functions are already stated. For context and environment, physical one is her rehab hospital. Social is visits by family and friends and staff at the hospital, and cultural setting is the Western medical setting in which the hospital she's in. Intervention approaches and frames of references. The approaches include restore confidence in ADLs, independence in ADL performance and healthy sleeping pattern, modify IADL simplification to reduce possibility of confusion or error, and prevent further cognitive recessions. The frames of references she will be undergoing are biomechanical frame of references, which applies knowledge from the anatomy, physiology, kinesiology, and physics to restore function, engaging occupations required by movement of the body function. And the multi-context treatment approach, which will address the dynamic nature of cognition and how participation in occupations is influenced by personal factors, occupations being performed, and the environment. Intervention activities and rationale for the via frames of reference. For the occupations, the biomechanical frame of reference rationale is ADL execution, and the multi-context treatment approach, or MTA, is IADL execution. For the activities, biomechanical rationale, breaking down ADLs by focusing on addressing sessions on specific activities that are most difficult, and the multi-context is breaking down IADLs by focusing during sessions on specific activities that are most complex, mentally taxing. Preparatory methods include the biomechanical HIP kit and the multi-context simplifying IADLs to adapt activity to facilitate improved client performance. Education, multi-context, improve self-awareness of impairments and utilize strategies to promote function and decrease barriers by, there are multiple ones you can see right here. And education is done. Training, multi-context again, instruct the client on how to perform simplified versions of IADLs, thus adapting the activity to allow improved performance. Finally, group intervention, multi-context, social participation during leisure activities that require problem solving, memory sequencing, visual processing, attention, e.g. simple board games, facilitates transfer of learning in social contexts. And finally, the service delivery includes who, rehab setting OTR, where, in the client's room for ADLs and some IADLs, and in a therapy gym or activity room for other IADLs and group therapy. When, ADLs during morning sessions, IADLs and group intervention during afternoon sessions. And finally, the frequency. Skilled OTR services 5 days a week, 2 sessions per day, each 45 minutes, and this will occur for 2 to 3 weeks before discharge, or until discharge. And that's the rehab section. Moving on to community.
Sophia Lord in community setting. Occupational performance problem area. Functional mobility, leisure, ADL, IADLs, rest and sleep. Social participation. Reduce participation in church activity. Reduce participation in family activity. Goal. Long-term goal. Mrs. Lord will perform ADLs and IADLs safely within functional limit by 4th OT visit without verbal cue. Short-term goal number 1. Mrs. Lord will recall hip precaution and humerus fracture precaution without verbal cue by 2nd OT visit. Short-term goal number 2. Mrs. Lord will transfer safely from bed to chair, from bed to bedside commode with standby access by 2nd OT visit. Short-term goal number 3. Mrs. Lord will transfer safely to shower bench and recall for precaution without verbal cue by 2nd OT visit. Causes of problem: performance skill, decreased functional mobility, difficulty processing information, decline cognitive function. Performance pattern: injury disrupted Mrs. Lord's mother and grandmother roles. Injury altered Mrs. Lord's routine and habit. Client factor: Mrs. Lord have decreased strength, decreased range of motion, decreased endurance, impaired global mental function. Activity demands: space demand for rolling walker, bedside commode, extra bedroom on first floor. Require body function and body structure. Hip precaution, humerus fracture precaution. Using grab bar in shower, using rolling walker, bedside commode, using handrail when going up and down steps of her home. Context and environment. Mrs. Lord needs these home modification. Handrail on both sides of stairs in front and back of her home and in the garage. Move her bedroom to first floor level. Grab bars in the bathroom. Adjustable shower bench. Bedside commode. Rolling walker. Portable timer when cooking. Intervention approach. Modify home environment to prevent fall and enhance safety. Frame of reference PEO. Using PEO frame of reference to find a best fit between Mrs. Lord, her environment, and her occupation. Intervention activity. Roam on right arm. Functional transfer within familiar context of her home. Rationale. Gentle roam on right arm will increase circulation and promote healing of the humerus. Functional transfer within familiar context of her home will promote Mrs. Lord's motivation to learn and speed up the recovery. Service delivery. Go treat with PT in home setting 1 hour a day 3 times a week for 4 weeks.